Okay, sorry.
And
Now I start the recording. Please go ahead. Sorry.
we will be talking about this paper called The Fate of the Unoperated Ascending Thoracic Aortic Aneurysm, 3-decade experience from the Aortic Institute at Yale University. I want to start by saying how fortunate I think all the trainees are to be learning under Dr. Borger. I had the privilege of being on the team that he brought together. He was the leader of the team that produced a position paper on bicuspid aortic valve. And I can tell you that there's no surgeon with greater experience in all aspects of cardiac surgery, or a deeper understanding, or a keener intellect for teasing apart difficult problems. You're in the very best possible educational hands with Dr. Borger. So in this paper, we looked at the natural outcome of 1,000 non-operated patients over 3 decades. And in this paper, we chose non-operative patients because in our prior papers, we had operated on some of the patients, and that dilutes the natural history of the disease itself. And in particular, we were interested in patients who suffered aortic dissection or aortic rupture. Of course, rupture of the ascending aorta without preceding aortic dissection is a very rare phenomenon. The abdominal aorta ruptures all the time without dissection. The descending aorta ruptures relatively often without dissection, but not the ascending. And especially this was relevant, this investigation regarding exactly where to put the criterion for intervention on the thoracic aorta. I want to start with one very important point, which isn't in the paper, but it's very, very important in these considerations. And that is that the dimensions that we measure after a dissection occurs are not the same as the dimensions that obtained the moment before the aorta dissected. The aorta grows by about 8 millimeters at the moment of dissection. So imagine how that throws off all of our strategy, because we have accessible to us only the diameter after the dissection occurred. I'd like to illustrate this for you. With a database as big as ours, we were able to identify a group of over 36 individuals who happened by happenstance, by accident, to have a dissection to have a CAT scan just before they dissected. There were 36 or more of those patients. This is one example. This gentleman was followed for a lung nodule every year with a CAT scan. I've taken each of those CAT scans and I've superimposed them perfectly so we can see the progress of this aorta year after year. 1 year, 1 millimeter change. Another year, 1 millimeter. 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 And then when the dissection occurred, you can see the 8 millimeter sudden change in the aorta. So this is a very important phenomenon that we must take into consideration in our strategy for prevention of aortic dissection. And Dr. Borger is the expert on bicuspid valve, but we did find in a study that we published just about the same time as the main study of our focus today, evidence that shows that the natural history of bicuspid valve is no poorer. As a matter of fact, it was a little bit better than a tri-leaflet aortic valve, and that's inherent to the topic that we're discussing. Now, in the particular paper of interest for our session today, this is the distribution of aortic sizes. The mean size was 4.6 centimeters. Here we see the rate of growth, and it was right around 0.1 centimeters or 1 millimeter per year. Of course, as the aorta got bigger, it grew a little bit faster, but even for the largest aortas, it was 0.15 centimeters, 1.5 millimeters per year. Here you can see that the patients without AAE, adverse aortic events, had a slower growth than those with aortic events. Age increased the likelihood of suffering a dissection. Hyperlipidemia decreased the likelihood. We can talk about that after this brief presentation if you'd like. And of course, aortic size was very strongly correlated with the advent of adverse aortic events. Now, I want to show you a few slides from another paper that was presented at about the same time as the paper of interest here. And we looked at rapid growth of thoracic aortic aneurysms. Was it a reality or a myth? My personal experience showed me that usually when a patient was referred from an outside institution and the doctor said, oh, this aorta is growing very rapidly, when we looked at the images critically and carefully, we found that it wasn't true. But anyway, in this study, Alexandra Sansino, led by Mohammed and others from our team, conducted a detailed study on rapid growth to see if it was a bona fide event. As you can see here, there were hundreds and hundreds of patients with growth at 1 to 2 millimeters per year, very few with more rapid growth. Here you can see I've even expanded this portion of the graph for you to see, and we're counting in the single digits the number of patients out of hundreds and hundreds and hundreds that were included in the study who actually grew rapidly. All the remainder were errors in measurement. And the trainees may, like this paper that we published in JACC, the Journal of the American College of Cardiology, dissecting apart the possible sources of error. Systole or diastole can make a millimeter or two a difference at each side of the diameter measurement, with the wall, without the wall, cursor within or cursor without the aortic diameter, and especially obliquity. If you measure non-perpendicular to the long axis of the aorta, you'll get an oblique measurement. This is a very, very common source of error. And then for the aortic root, who knows what to use as the diameter? And I'm going to focus for a few minutes at the end of the presentation on measuring the aortic root. This is the most important slide that I have to show regarding the paper that you asked me to discuss. And please note that at 5 centimeters aortic diameter, all the rates increase. Adverse aortic event, aortic death, dissection or rupture. Rupture itself, I'm not going to look at because it's such a rare phenomenon. And you can see this abrupt change. It's not a mild change or a soft change. It's a very abrupt change in all of these adverse outcomes when the aorta reaches 5 centimeters. Here we see that displayed another way as the outcome over a long period of time with different aortic dimensions. And here we go again. You can see the dramatic change from the flat natural history at smaller sizes to this threatening natural history at 5 centimeters, and even more for 5.5 and 6 centimeters. Even more serious is the future at those dimensions. Here, we look at the relative risk of an event compared to the risk at 4 centimeters diameter. This is the relative risk. And please note that when you hit 5.5 centimeters, there's a 10-fold increase above what the risk was at 4 centimeters aortic diameter. And here I'm showing you the long-term outlook. This is 20 years, two decades. You can see there's still a lot of patients at 20 years because the standard deviation is small. And you lose about 40% of all of these patients. But remember, their average age was already in the mid to upper 60s. And then Mohammed and his colleagues produced this table where you divide aortic size by the height in meters. And this will put your patient in one of 4 groups indicated by colors here, with the highest risk where the diameter over the height gives the highest numbers. And then they also produced this very attractive graph where you input aortic size and age in years, and you can predict the exact 10-year risk of an adverse aortic event. You can see that for the very large sizes, These are very substantial risks from the aortic disease. So the guidelines have changed. We've been arguing for about 5 or 6 years, maybe 7 years, that our data indicated that we would switch from 5 to 5.5. And the AHA and American College of Cardiology combined guidelines have now switched the criterion for intervention to 5 centimeters for healthy patients at an experienced center. So indeed, our guidelines have switched. I can't tell you yet the European guidelines. They'll be published very, very shortly, and I can't really speak to those yet. But we've learned, number one, that the risk of aortic events is flat until 5 centimeters, that there's a very rapid rise in risk thereafter, that the mean growth rate of the dilated aorta is 0.1 centimeters per year, that rapid growth is nearly mythical. It almost never happens. By the way, when it is bona fide rapid growth, the outlook is very poor. And unless the patient is operated, the patients go on to a rapid death. And we recommend, as the guidelines are doing now, a left shift in the general criterion for intervention from the prior 5.5 to the current 5.0 centimeters. So those are the main messages from the paper. I'd like to spend the next 3 or 4 minutes discussing some related important findings that are not directly in that paper. And this is intended mainly for the trainees. Mohammed, who's with us on the call, and his team have found that aortic length is also an important predictor. And please keep in mind that the top and bottom of the ascending aorta are fixed. If it lengthens, it can't move up outside of the chest or down into the abdomen. So when it elongates, it takes a more exaggerated C curve, as you see here. Remember, we used to think of tortuosity of the aorta, especially the descending or thoracoabdominal, as just a curiosity. It's not a curiosity at all. When the aorta is weak enough to grow in diameter, it's also weak enough to grow in length. So the length measurement that Mohammed has developed is significant. We measure the length of the aorta from the aortic valve to the base of the innominate artery. And please look here, diameters does separate patients without events from those with events, but look how well length separates, even better than diameter. And some of you may in the past have seen our hinge point graphs. Diameter has 2 hinge points of risk. And here we see that length also has 2 particular hinge points at 11.5 and 12.5 centimeters in length. A normal length is 9 centimeters. And we recommend intervention at 11 centimeters. We don't know yet why that double hump is. I think Mohammed will figure that out in another year or so. We think it might be related to patient gender because the body sizes are different. So the guidelines have shifted now to 5.0 centimeters as a general criterion. Now, some people have criticized. They said, John, you're recommending that we move too early. But let me show you, this is a histogram of all our type A dissections in a recent study that one of our students did. And please note that even with a 5 centimeter criterion, we're leaving behind a good number of aortic dissections. So I think this shows that our criterion is not improperly aggressive. And diameter, why is it used so widely? Well, it has some advantages over other predictors. Simplicity, accessibility, everybody knows how to mention diameter. And it's an inherent endorsement of Laplace's law. We know Laplace's law, which is based on diameter and blood pressure, really shows us the degree to which the aortic wall is threatened. Now, measuring the ascending aorta is pretty easy unless you fail to orient the plane properly to be perpendicular to the long axis of flow. But the aortic root is very, very hard to measure. And I'll take the next couple minutes and then I'll be done. I'll take the next couple minutes focusing on measurement of the aortic root. And we recently published this new technique for measuring the aortic root. It's not a simple issue. It's a special location. How can you even state what the diameter is of a cloverleaf? Diameter refers to a circle or a cylinder. It has no meaning for a cloverleaf. And of course, we know that the embryology of the root itself is different from that of the ACE and the aorta, with the root originating from cells in the second heart field. And every institution measures it differently, the root. And even within one institution, one radiologist or one surgeon may measure it by a different technique. So we thought it was worthwhile focusing on that. Again, diameter is applicable only to a circle or a cylinder. What is the diameter of a cloverleaf? Many centers measure from the from the commissure to the opposite sinus. Others measure from sinus to sinus. I favor, with traditional techniques, I favor the coronal view, which gives you a pretty reasonable diameter. Of course, please keep in mind, picture that aorta rotating to different coronal views, and you may not have captured the largest coronal view. It may be hiding into the screen or outside of the screen of your image. But here, at least, the coronal diameter gave us 45 centimeters. I'm going to show you that patient with our new measurement technique. So we went to our distinguished bioengineers, and they calculated mathematically an appropriate way to measure the aortic root. They went back to basic fundamental geometry and mathematics and developed a new method for us that we've been applying. And it involves constructing 3 lines from the commissure to the opposing sinus. And I'll show you how we use those lines to get the measurement. Those 3 lines determine what we can call the center of the cloverleaf of the aortic root. And let me show you what we do with those. So we think that the real diameter is the diameter of a circle, the smallest circle that can enclose every part of that cloverleaf, as you see this yellow circle is doing here. I'm going to run this very short video that shows you how we do it. It's a 45-second video. But first, we have to locate our crosshairs optimally in all 3 planes: coronal, sagittal, and axial. You see how I've located precisely at the largest part of the aortic root. And then let me play this for you. So we construct those 3 lines from each commissure to the opposing sinus, and then we measure to find the largest radius. And here it's the 24.2. And then we double that radius, and that gives us a mathematically justified aortic diameter. So here we get 2 times 24.3, or 48.6, which is even a little bit larger than the 45 we got on the coronal view. And that makes sense because, again, the coronal view may not be capturing the largest diameter. If you were to rotate that aorta, you might get a bigger one. So we recommend this technique. We've tested it and found that it's very reproducible. It's easy to do once you get used to it. And we know from our colleagues in mathematics and engineering that it more appropriately represents the tension in the wall of the most dilated sinus. So we've talked all about size, but in closing, I want to emphasize that size is not the only factor that should influence our decision-making. And recently, at the Liverpool Aortic Symposium, I was asked to talk about other factors besides size that enter into our decision-making, and I put them in this table for you. Pain mandates surgery. Length is important. As we discussed, the genes are very powerful. That's outside of this current topic. If you want me to talk about genes in the discussion section, I'm happy to do so. Family history dramatically increases risk. Bicuspid valve is no longer a separate risk factor. Diabetes is actually protective of the aorta and discourages dissection. I can talk about that more if you want. The degree of stress that a given individual's aorta undergoes in daily life, especially through weightlifting, must enter into the gestalt of decision-making. I can talk to you about some biomarkers that are nearing validation. We've just validated this gene KIF6 as a strong predictor of adverse events. And we've shown in recent papers that the root is more malignant than the ascending aorta. So a given level of dilatation in the root should be more concerning than in the aorta. After all, the root is thinner. And PET imaging can light up aortas that are in marked jeopardy. We have trouble in the US getting paid for PET images, so we don't use them very often. I've put these into this illustration. I've illustrated each of these other factors that should go into our decision-making. This paper with this analysis of the non-size factors appears in a recent edition of our journal, Aorta, and you can find it very easily there by just clicking Aorta Journal. So this is my presentation of Mohammed's work about aortic diameter in non-operated patients. It's my privilege to be here with you. I'm going to stop at this point. I look forward to our discussion. And let me ask Mohammed, do you have anything to add or correct or make more precise from the preceding slides?
Nothing from mine, Dr. Elefteriades. Very comprehensive. Thank you.
Okay, Mohammed, please help us with any questions that come up.
Of course.
John, maybe I can jump in with the first question, Matteo, if that's okay. John, fantastic presentation. And for those of you that have not heard him speak before, I think he only showed 1/1000th of what he knows. He can talk about this subject extensively in so many different aspects, and it's really a great pleasure for us to be able to listen to you today, John. I just had one comment and also one question. I think a lot of people listening today would be surprised when you said bicuspid aortic valve is no longer considered a risk factor, and there is increasing evidence. A lot of it still hasn't been published, but a lot of it is being gathered now to show that the bicuspid aortic valve aorta is actually very stable, especially if the patient has aortic stenosis. It's a bit different if they have insufficiency, especially with dilatation of the aortic root. And maybe I would just get you to comment on that, John. So that's one question is, why is it that aortic insufficiency seems to be associated with an increased risk as opposed to the post-stenotic dilatation in the tubular aorta? That's one question. Second question is, or maybe more of a comment, is the length of the aorta. As you know, this has been demonstrated by a few working groups now, including Martin Czerny's group. And I strongly believe this is something really, really important. We need better ways to measure this variable and better data to really show the cutoffs. I've operated on many type A dissections. I've never seen a patient with a short aorta with a type A dissection, just never seen it. And oftentimes the ventricle on the pre-op CT is very horizontal because the aorta has elongated so much, and then the heart ends up rotating. So maybe because the length is sometimes hard to measure for people that are not good at these measurements, maybe even the axis of the heart is another thing that you could look at that's a little more reproducible. I don't know. And then the third thing I would just say is that, you know, you also previously published a work where based on the American databases that only 2% of centers do more than 50 ascending aortic operations a year. I think it's great that we've gone down to 5.0 centimeters in the current guidelines. I think we could even go further down if we had better ways to determine those patients that are at risk. But we always have to take into consideration the risk of the procedure. And once we get into the root, it gets more complex. So you're not concerned. Maybe some people may say, oh, 46 millimeter root, I need to do a David operation, and that could be too risky in their hands.
Thank you very much, Michael, for those important insights and the questions. Let me start with the third one about centers' experience and proficiency at performing these operations. I agree with everything you said on each of those topics, Michael. I agree wholeheartedly. The replacement of the aortic root, it's a very, very, very serious operation. I couldn't agree more. And we haven't talked about the technical aspects. We recently published a book called Practical Tips in Aortic Surgery. It's ideally suited to residents, and it goes over hundreds of suggestions about how to make operations, especially the composite graft operation, safer and more secure. But mobilizing the coronary buttons, attaching the coronary buttons, getting them to be secure and not to bleed, and getting them at just the right angle. If you're off in the location or the angle or the rotation of the button on its axis, you have a lethal problem on your hands. And I couldn't agree more that with your comment, Michael. The ascending aorta, it doesn't have any of those complexities if one is doing a supracoronary replacement. But I couldn't agree more. I think operating at 5 centimeters or maybe even lower has to be predicated on having a center with great experience and demonstrated proficiency at delivering safe operations. I couldn't agree more. In terms of your first comment about the bicuspid valves, you're really the world's authority on bicuspid valves, and I would yield to any insight that you had. Just for the residents, I would say that there's Marfan's disease that our surgical field has always thought of as justifiably malignant. When I was in my earlier career, we thought of bicuspid valve as Marfan's light. Do you guys know about Miller Lite, the beer, which has a little less alcohol? Well, we called a bicuspid valve disease Marfan's light because we thought it was a serious risk factor. And we wanted to call that to attention. And then it's become apparent that that's less and less true than we thought. That's what was shown in the paper that Michael wrote on behalf of the committee that he convened. In terms of the impact of the type of valve disease on the malignancy of bicuspid aortic dilatation, I think that's a very important point, Michael. I think you know more about that than I do, but in terms of speculation about the mechanism, I think maybe the wide pulse pressure of aortic insufficiency might be a factor. We know that the systolic pressure is higher because the heart has to eject twice as much volume. So the systolic pressure, while the aorta deals with that stroke volume, is higher and the diastolic pressure is lower. Maybe that might be a hemodynamic factor that would tie in aortic insufficiency. In terms of length, I agree entirely that it's a little bit cumbersome to measure length. Radiologists aren't used to doing it. Cardiac surgeons aren't used to doing it. Cardiologists, I don't think, ever do it. I don't think cardiologists, well, I should be careful, but I don't think they're as tuned in to the different portions of the aorta and to the different ways that the diameter can be improperly measured. We live and die by those measurements, so our specialty has focused on them a lot. My hope is that we can automate the measurement. What I can say so far is that all the programs that we've looked at, whether they're Visage or any of the other commercial programs, and you may have some in Europe that we don't have here, they can all draw the center line. I think drawing the center line is a common modality to all modern CAT scan radiographic systems. I think once the center line is drawn, then we have to place the endpoints at the aortic valve. I like to place it at the aortic valve itself because it's constant, and then place it at the base of the innominate artery, I think is a nice way to do it. And then also the program that draws the center line will straighten that line and give you a dimension. I would like to automate it though, to make it a one-click process. And we've started some work on that, but there's a lot of work ahead. So those would be my responses to those very important points that you brought up.
Thanks a lot, John. Matteo, or some of the other residents or surgeons on the call?
Yeah, I actually do have two questions. First, thank you very much for the great talk. I really feel privileged to have been able to be here, and I'm happy you recorded it because I'm surely going to watch it again. So I have two questions. My first question is, you talk about let's say the exact numeric threshold to operate, but what do you think about indexing to the body size? Because as you know, there might be, for example, a small female patient in whom a 4.5 centimeter aorta might be already the equivalent of a 5.0 centimeters in a big patient. And that might apply, for example, for other countries like, I don't know, Latin America, maybe, where people are usually a little bit smaller. So that's my first question. And my second question is, what about the threshold when we are performing another kind of cardiac surgery, like, I don't know, aortic valve surgery, mitral valve surgery, or even in TAVI patients? Because I saw in one of your graphs, you have one great graph where you compare the age with the diameter, and then you can calculate or see the risk of adverse events. And you can clearly see people start having a high risk after their 70s or 75 and after 4.5 centimeters. So what about patients who are scheduled for TAVI, but they have, like, let's say, borderline aortas, and they might be in a good shape to be operated, actually?
Matteo, those are great points that you bring up. I wanted to keep the official presentation short, so we would have lots of time for discussion. And you recommended about 15 or 20 minutes, so that's what I did. But we're big believers in indexing. Mohammed and I and the rest of the team, we're big believers in indexing. And for years, we've indexed aortic size to body surface area. But then, we started to think, well, how does your aorta know if you've gained 40 pounds? And why does it care? So then we jettisoned weight and body surface area, so you don't have to do any calculation of BSA. You don't need a program on your iPhone or a nomogram on the computer. And we found that indexing to height is perfectly adequate. And we do that. I didn't emphasize it in this talk because for a wide range of heights, we use 5 centimeters. But for very short patients and very tall patients, we index them in order to fine-tune our decision-making. For example, I have a gentleman, he was a basketball player in college. He's 6'7", and I've followed his 5.5 centimeter aorta for years. It hasn't changed at all. And I think that may be the appropriate size of his aorta. And on small women, we've operated on them sometimes at 4.2 or 4.3 centimeters because of the indexing. So I couldn't possibly agree more with your point about the indexing, and we use it extensively. Your other point about the threshold, if we're operating for the valve, or even for another reason, what do we do with the moderately dilated aorta? And I was asked to give a talk on that. What was it, Mohammed? About a year or two ago, I think. That was the topic that I was assigned at, I think, an international meeting. So I looked into the literature, and I also looked at my own experience. And I found that that I resected the aorta if it was 4 centimeters or greater. If I was there for the valve or if I was there for a cabbage, I just resected it if it was 4 centimeters or greater. And then I found a paper that Lars Svensson had published, and he did exactly the same thing. The literature supports 4.5. That would be if you were taking your boards, you should say at 4.5 centimeters, you resect it. But in our experience and in Lars' experience at the Cleveland Clinic, there was no additional mortality from a supracoronary resection of the ascending aorta in either of our experiences. So that's what we use. Michael, what do you do in that setting?
Sorry. Okay, I can hear me. I look at it more as a bit of a patient-specific situation. So, for example, if we're replacing the aortic valve and it's stenotic, whereas we think that most of the aortopathy is due to the downstream turbulent blood flow and that should be corrected afterwards, then I'd be a little bit more conservative, let's put it that way. And I would say, okay, 4.5 or bigger. But if it's a young person where, for example, the aortic root is a bit dilated, but they have, significant aortic insufficiency, then my threshold is pretty low to do a David operation, to be honest, if they're young. But you and Lars do a huge number of aortic operations, and I think it's really important for the people that are listening today. I don't have anything against doing a supracoronary ascending aortic replacement, as long as there's very, very good results, and I know we are capable of doing that in Leipzig. But for the younger people that are just starting out on their career, I would say let's stick with 4.5 centimeters as the cutoff.
Thank you.
But maybe, John, maybe we need a combination of diameter, height, and length of aorta in order to get a little bit more granularity to that question.
Yes. Mohammed, what do you think? Can you do that?
Yes, Dr. Perez, I think we can work on it. Yep.
And the other thing that gets stressed a lot in the guidelines, which I really like, the American guidelines and the European guidelines, John, I'm sure you've seen them as well. They're not going to be very far from the American ones. But what I really like is how they stress the importance of the family history, that so markedly increases your risk. So that's also a question I always ask the patient the night before the surgery if it's a borderline aorta.
We found a 2.6 multiplier of risk when there's been one dissection in the family. So I agree. I think your policies and our policies at Yale superimpose perfectly. But if a patient is sitting in front of my office and he's got a real aneurysm, even if it's 4.2 or 4.3, and a family member has dissected, I offer surgery if they want it, because I think it's just a matter of time until it happens. And as I showed in that histogram, we're still leaving behind, a substantial number of patients who dissect before our criteria. And I think most of those would probably have a family history. So I couldn't agree more. That's one of the 14 other factors. Where do I have family history here? Right here. Yeah.
Are there other questions from the rest?
I would have one question actually. First of all, I'd like to thank you as well for your very educational presentation here. And one question that I do have left is, since you've looked at so many independent factors that might have influence on the outcome of patients with an aneurysm of the ascending aorta, what do you think of creating a composite score to evaluate the individual risk of those patients?
That's exactly what we're doing now. we're working with a very experienced non-medical aortic artificial intelligence team. It's a team that figured out how to beat Wall Street. And they can make their assessments of direction that a stock is going to go about 3 seconds quicker than anyone else. So they've done so well that they want to contribute to the well-being of mankind. They're also the ones who analyze the Formula One racing data, you know, coming from those engines and chassis. And through unexpected circumstances, we came in contact, and they're doing exactly what the commenter is envisioning, combining all of these factors into one automatic decision informing tool. Exactly what you said, sir, is exactly what we're doing.
John, can you ask him what's going to happen with the stock price for Fresenius, please? That's a small joke that the people on my team will understand. Adjun Murad has another question for you.
Hello,
yeah.
Dr. Elefteriades.
Hello.
Thank you very much for being with us today. It's a great honor for us. And I have a question. Since the guidelines are moved from 5.5 to 5.0 and made this 2A indication for surgery, there are some trials, some ongoing RCTs, one of them Titan SVS from Canada, where our colleagues are wanted to look at the aorta from 5.0 to 5.4 centimeters in terms of surgery versus surveillance. Do you think we have to expect some surprises from this trial, or it would give us more information and more data to make, in the new revision of the guidelines, this 5.0 cutoff class 1 recommendation for the surgery, in even some ways to go further with the diameters? Thank you.
Yeah, that's an excellent question. Very, very good question. You know, we also have thought about doing a trial like that. I got worried about the ethics of it. You know, if I was worried about a patient, would I be able to let the computer triage that patient to non-operative management? And we never started it, but I think it's good that it's being done. I hope it's extremely revealing. My fear is that it may be hard to get enough events in the two groups within that range of aortic size to get very decisive analytic data. I hope it clarifies that. I think it's good that they're doing it. I think the numbers may make it difficult.
Thank you.
Significant risk that it could be underpowered, right, John? But we have another question in from Ibrahim.
Yes, thanks a lot, Michael, and thanks a lot for the great informative presentation. So in patients who got aortic valve replacement and supracoronary ascendance replacement, because you mentioned that the root is very dangerous because it's thinner than the tubular aorta. What's your experience with these patients? So do you have a lot of patients coming for reoperation for the root after having such operation, or are the results age-dependent and risk-dependent? Thank you.
Yeah, we have not had any adverse events in the aortic root. As a matter of fact, we wrote a paper looking at some very nasty looking roots after type A dissection repair, and they don't rupture. I don't know if Michael's experience will be the same, but at the Houston Symposium a few years ago, we had 10 people on the dais there, you know, speakers, very experienced. And I asked if anybody had ever seen one of these nasty looking aortas after a supracoronary resection for type A dissection, and nobody had ever seen one rupture. They can look terrible, but I think if it's not big enough to replace at the original operation, I think with all of the adhesions that you get down there, I think they're going to be safe. Michael, what do you feel about that?
Yeah, Sorry. Yeah, oh yeah, okay. Yeah, I'm a bit torn on that one, to be honest, John. When I was in Columbia, New York, the congenital or the Gooch cardiologists oftentimes hit me with this question. You know, the typical one was a patient after a switch operation, and now they're 30 years old and they have an aortic root of 5.8 centimeters. What are we going to do? Or with the aneurysms after Ross operation. I've operated on several of them. The switch patients can be particularly challenging if they have the Lecomte maneuver, and then you do some, you know, complex aortic root surgery, and then you have to tuck it in behind the pulmonary trunk at the end of the case. It's kind of scary, but they told me that they had, you know, at least one patient where the congenital surgeon did a reoperation for whatever reason on the right side of the heart, and then left the aortic root aneurysm alone, saying these don't rupture. And they had two bad outcomes, young patients that died a little while later. Maybe it was the reoperation that somehow loosened up the adhesions that would have kept the patient alive before. I really don't know it, but it's an area where we definitely need more data on and some guidance.
Very good, thank you. I don't have any experience with the congenital pathologies.
We have another question from Yagdip.
Yeah, thank you, Dr. Elefteriades, for your great talk. My question is also concerning about the indexing of the aorta. Did your team look into, like, so if you take an aortic cannula for any surgery, you know, if your patient has that weight, that size, you need this big cannula to perform the surgery, that the cardiopulmonary bypass can deliver enough flow. So, like, did you measure which would be the ideal aorta for a patient with certain size, and then looked up so what the range would be, like where it should be, and then if it's higher than this normal range of size, that maybe one should perform the surgery then?
Yes, I think what you're describing is very similar to the indexing that we do. I think you're conceiving of it as different ranges, like, you know, 5 to 5.25, 5.25 to 5.5, and so on. We have not compartmentalized like that, but I think the indexing accomplishes a similar purpose. Am I understanding correctly your question?
Yeah, it's like the example you delivered, that the basketball player who's 6'7", and he plays basketball in Division I. He needs amount of cardiac index to perform this exercise, and therefore his aorta must be bigger, that enough flow can go through this aorta. So my question is kind of in this range, that maybe we should look how much flow has to go through the ascending aorta, and if the aorta is appropriately enlarged for such increased flow requirements, or it is more than the range it should be for such flow requirements.
Yeah, I think that's a valid point of view. I think the flow requirements would be proportional to body size, and we use body surface area in the operating room to determine the flow. But I think that's a good reasoning. The basketball player that I mentioned, by the way, he's 68 years old now. I followed him for about 10 or 12 years. I didn't want to give the impression that he's, you know, a 25-year-old playing ball now.
John, did you see that paper though from Columbia where they ended up screening all of the NBA basketball players? I think it was like 250 players, and the largest aorta that they saw in anybody, even, you know, those guys are, some of them are 2 meters and 15 centimeters, so like 7'6", was, I believe, 4.7 centimeters. Is that correct?
I did see that paper. I don't remember the details. And I looked at that carefully. I was hoping to learn a lot from that, and I did. Yeah, so I think your point is well taken. This patient is larger than in that study.
And John, if I can just, maybe we'll wrap it up, but if I can just point out one other thing that I learned from you, which I found so fascinating, is if you're asking patients about family history of aneurysms, and you're thinking, oh, maybe this person has some sort of connective tissue disorder, not typical marfanoid or typical Ehlers-Danlos, but you told me one time a really good sign is to get them to try to bring their thumb out across the other side of their hand. And I still haven't seen that paper from your group, but I do that all the time now. And if you see the thumb poking out on the other side of the hand there, it seems to be a pretty sensitive finding, if I understand correctly.
Yeah, it's 100% specific.
Specific, not sensitive.
Specific. If it crosses over, you've got connective tissue disease. If it comes out that far. It's not sensitive at all. It doesn't mean that you don't have aneurysm disease if it's not positive. The funny thing, we published that paper a couple years ago, and it was picked up by the rags. I don't know what you call them. The
Yellow press. We call them.
What do you call them?
Yellow press.
Yellow press, and the News of the World and stuff like that. And it was on the front page of all of those newspapers. They picked it up and they each drew their own diagram of this. So, and when I give a lecture and I talk about it, everybody does this. Out of 100, 200 people, there are usually 2 or 3 whose thumb goes across. And there's no cost, and it's 100% specific. So I'm glad that you found it useful. That means a lot to me. I didn't make it up.
All of my patients that have a genetically confirmed syndrome, I ask them to do that. Every one of them, it crosses over. It's amazing.
Yeah, I didn't make it up. It's been known for 100 years, but we tested it scientifically and found that it works.
John, Mohammed, I think, Matteo, if you're okay, I'll wrap it up. We don't want to hold you up any longer. We really, really, really appreciate you taking the time to speak to us today. You've taught us so much in the past, but again, also tonight. And thanks again. It was a great honor and a great privilege to have you here today.
The honor and the privilege are ours to be able to spend this time exchanging ideas with you. Thank you.
Thanks, John. Thanks, Mohammed.
Thank you.
Bye-bye. Thank you.
Bye.
Bye.